Now we're going to move on to evaluation of the spine, including the cervical spine, thoracic spine, and lumbar spine. If I could please have you stand up and you could take the robe off. You want to make sure that the patient is adequately exposed for you to be able to see. Thank you. You're welcome. We're going to take this all off. Is this okay? You want to make sure the patient is adequately exposed so that you can see all areas of the cervical, thoracic, and lumbar spine. You're going to want to look from a posterior view, noticing if there's any lateral curvatures that might indicate scoliosis. Also using your landmarks to make sure that the base of the occiput is level, the shoulders are level, and the iliac crest are level. Turning to the side, you're going to want to look at alignment, noticing if there's any anterior head carriage, if there's a normal lordotic curvature of the spine, normal kyphotic curvature of the thoracic spine, or normal lordotic curvature of the lumbar spine. And then again, you can assess stature from the front as well. So after inspection, you're going to move on to the palpation portion of the examination. If I could please have you take a step forward. You're going to want to start with the base of the occiput here, feeling for any muscle tightness along here or tenderness. You're also going to want to feel midline for any step-offs, and move your way all the way through the spine midline, feeling all the spinous processes throughout. Again, feeling for musculature or your tart texture changes on the paraspinal musculature. Is there any tenderness, bogginess, ropiness, or any kind of spasm? And then you can also feel the articular pillars, again assessing for any rotation component of the T-spine. And lumbar spine. You don't want to forget about the PSIS down low, assessing for height discrepancies there, iliac crest discrepancies, and palpating the sacroiliac joint, as those can all be sources of pain. Now for range of motion, can you please bend forward and touch your toes? You're testing for overall flexion. Go ahead and come up. How about looking up at the ceiling and arching your back, assessing for extension. And we'll go ahead and have you take a seat for me, please. And then you'll want to assess the range of motion of the cervical spine. So if I could have you tuck your chin to your chest, we're looking for flexion. If you could look up at the ceiling, you're assessing for extension. If you could turn and look over your right shoulder and your left shoulder, assessing for rotation, and then bringing your ear to your shoulder, again on the other side, and that's assessing for side bending. You want to finish the evaluation of the spine by doing a test for neural tension, which is called the straight leg raise. If I could please have you lay down for me. You're going to want to take your cephalad hand and kind of stabilize the patient's hip. With your caudate hand, you're going to grasp the patient's ankle, and then you're going to flex the leg somewhere between 30 and 70 degrees of flexion, and you're wanting to see if this elicits any pain radiating down the leg and into the foot. If the patient does not experience any pain with that range of motion, you can add a little extra tension by dorsiflexing the foot and seeing if that causes, again, any numbness, pain, or tingling down into the foot itself.